Really, really exciting. We have today Dr. Javon Edgecombe, and I hope I'm saying your first name right. He was born in Grand Bahamas, and is the graduate of Lincoln University. He obtained his medical degree at Pennsylvania State University. He completed his neurology training at Thomas and Jefferson University Hospital before completing his vascular neurology fellowship at Washington University in St. Louis. And in fact, just a little interesting note, the founder of Geisinger, Abigail, had bequeathed money to Lincoln University. And I believe the last time that we had checked, it was in the hundreds of thousands at that particular time. So we are so pleased to have you, Dr. Javon Edgecombe, and we're all waiting in anticipation of what you have to teach us and learn about this important health matter. I'm turning it over to you.
Thank you so much.
So I will stop my share and I will give you the controls, sir.
Okay, let's see if this will allow me to do what I am intending to do. Can you see the screen?
We can.
Yes.
Perfect. Thank you guys for having me. And as you said, the title for today's talk is Stroke in the African American Male. I feel that whenever we talk about stroke and we talk about disparities, we always, for the most part, tend to link just African Americans all together, and we don't separate by sex. And there are a few topics in regards to disparities specifically within African American men that I feel need to be addressed. So I wanted to go over a few basic terms first. Basically, what is a stroke? And a stroke occurs whenever a blood vessel that carries oxygen to the brain, it either is blocked or it ruptures. And that basically causes impairment in blood flow to the brain. And as an end result, there is cell death that happens. There are two main categories of strokes. We talk about ischemic strokes, and then we also talk about hemorrhagic strokes. And when the majority of strokes tend to be ischemic, and that just means that there's a blockage within the blood vessel, and that blockage can arise from multiple different etiologies. When we talk about hemorrhagic strokes, or sometimes people would just refer to these as bleeds, we talk about the vessel wall actually rupturing itself. And again, the etiology varies as well, from things like hypertension, or if you have an aneurysm. And in a typical assault or stroke, it's reported that about 2 million neurons, about 14 billion synapses, about 7.5 miles of myelinated fibers are lost every minute. So that's a lot of precious brain architecture that's lost. And so time really is brain. And I know we hear that all the time, but it is absolutely true. When we talk about treatments for ischemic strokes, we have a medication called TPA that can be administered up to 4.5 hours of the last time someone is known normal. And then there are also endovascular therapies that can be performed up to 24 hours after someone has a last known well. And as the years have progressed, the field of interventional stroke has moved forward pretty swiftly. When I was in training, interventional procedures were usually only possible if stroke symptoms had occurred within 6 to 8 hours of the time that someone was last known well. And just over the course of the past 5 to 6 years, that has now progressed to about 24 hours of the last known well. And so this just highlights the need for patients to present to the ER as soon as possible. And when we talk about quick facts, so about 800,000 people have strokes within the United States every year. And about 185,000 of those strokes are in people who have had a previous stroke. So that's nearly 25%. Every 40 seconds, they say someone dies, not dies, but every 40 seconds, someone in the United States has a stroke. And that basically means by the end of this hour, we would have had about 90 new cases. If you ask me, I think that's probably a gross underestimation. And it's also reported that every 4 minutes, someone dies of a stroke. So at the end of this talk again, that's about 15 lives that we're going to lose. And when we talk about stroke and its impact, sometimes it makes more sense to, or it makes more of an impact when we talk about the financial burden that eventually happens. And within a year, I think they looked between 2014, stroke-related cost was nearly $50 billion. And that includes the cost of healthcare services, that includes the cost of medicines to treat stroke, and that also takes into account the missed days of work as well. And stroke reduces mobility in more than half of stroke survivors, especially if they're over the age of 65. Besides talking about stroke, there's another term that's thrown around a lot in the medical world, and it's TIA, or transient ischemic attack. And I have a little bit of a love-hate relationship with this term, specifically when people refer to it as a mini stroke, and we'll get to that a little bit later. And what a transient ischemic attack is, it's an episode where you have neurologic dysfunction, whether that's in the brain, whether that's in the spinal cord, whether that occurs within the retina. But like the name implies, those symptoms resolve. And when they resolve, when we look at the brain, specifically with an MRI or other imaging modalities, there is no end damage to the brain. So it was an event that was in the process of happening and for whatever reason was aborted. Whenever we say TIA, again, it implies that it's a focal ischemia, meaning that symptoms have to be relatable to a specific arterial territory. So for example, sometimes we may be consulted on patients who may have had, let's say, an episode of generalized weakness, or they've had bilateral blurry vision. Again, those symptoms are not very localizable. Years ago, the term TIA was mainly a time-based definition, and some people may still use that. And the arbitrary time that was picked was that if you had symptoms and the symptoms lasted less than 24 hours, that was a TIA. But that's a little bit misleading because you can still have a stroke, meaning that if we look at your MRI, we can actually see the end organ damage in the brain, but your stroke-like symptoms would have lasted less than 24 hours. So I favor the radiographic definition or the tissue-based definition. And when we talk about TIAs, there's a way to grade them. And it's a score called the ABCD2 score. And it takes into account your age, it takes into account your blood pressure, it takes into account features of that TIA that you had, whether you had weakness on one side of your body, whether or not you had speech issues, the duration of the time that the TIA lasted, whether you have a history of diabetes, and it gives you an overall score. And what I like to stress is that transient ischemic attacks, or TIAs, are not benign events, but they're rather a critical harbinger of impending stroke. So if you fail to quickly recognize and evaluate this warning sign, this is the first opportunity you would have missed to actually prevent permanent disability and, God forbid, death. So when you look at someone, let's say, who's had a TIA, and looking at the factors before in that ABCD2 score, you can stratify someone in a risk group and say, okay, you have a low, moderate, or high risk based on the TIA symptoms that you had. And that actually predicts your risk of having a stroke within the next 3 months. So that can happen within a 2-day time span, and you can see whether or not you're low, moderate, or high, which your risk is going to be at 2 days, which your risk is going to be at 7 days, and which your risk is going to be at 90 days. And unfortunately, when we talk about stroke and TIAs, the disparities kind of start right off the bat. And they exist at every juncture along the TIA stroke spectrum. So there was a longitudinal cohort study that was done, and they were trying to analyze whether Black race and other cerebrovascular factors have a differential effect on your first or your recurrent stroke event. And there were about 30,000 patients, and in 3,000 of the patients in that group, they actually had a TIA or stroke previously. And then there were 27,000 patients who never had a TIA or never had a stroke. And they followed them for about close to 7 years. I think they say like 6.8 years. But in the patients who actually had a TIA or a stroke previously before, they were most likely to be number 1, male, and they were most likely to be number 2, Black. And ultimately, even if you never had a TIA or a stroke, your risk of actually having a stroke during that follow-up period was significantly higher compared to your white counterparts, close to 3 times. And so there are huge gaps that exist and differences, and it doesn't matter which category you actually belong to. When we talk about the stroke death rate, unfortunately, African Americans are about 50% more likely to have a stroke compared to their white counterparts. Black men, unfortunately, it's about 60 to 70% more likely to die from an actual stroke when you compare them to their white counterparts. And when we talk about stroke risk factors, we're talking about modifiable risk factors and we're talking about non-modifiable risk factors. And the modifiable risk factors are really the ones you can control, and non-modifiable are the ones that you cannot. So when we talk about modifiable risk factors, we're talking about things like obesity. We're talking about things like obstructive sleep apnea. We're talking about heavy alcohol use, diabetes, high cholesterol, hypertension, cardiovascular disease in general. And we don't have enough time to cover all the risk factors individually. So I'd like to focus on what I consider to be the most important, which would be high blood pressure. And then what I consider to be the most overlooked stroke risk factor, especially when we're talking about African-American males. So the first one would be high blood pressure because it's a contributor to both stroke types that we talked about earlier. We talked about, ischemic strokes and hemorrhagic strokes. And then obstructive sleep apnea, just primarily because I feel it's very under-recognized. And then the non-modifiable risk factors, like we talked about before, you can't control your age, you can't control your biological sex, you can't control your race, you can't control your family history. And so why are African-American men at higher rates subjected to this increased stroke risk? 30% of African-American men, they have an LDL that's greater than 130. About 1 in 9 African-American men have been diagnosed with diabetes, but the more concerning issue is that there's actually a lot more, but they have no idea that they have the underlying disease process. 1 in 5 African-American men smoke. About 7 in 10 African-American men are overweight or obese. So when we go back to that chart and we talked about all those modifiable risk factors, we have all of them where the increased risk for all of them. And then there are disease-specific genetic disorders that affect African-Americans, specifically sickle cell, that also increase our overall risk of having a stroke. So high blood pressure. So about 40% of African-American males have a blood pressure that's equal to or greater than 140/90, or they're taking blood pressure medications to control that. The concerning issue with that is that about 60% of those patients who are taking their blood pressure medications, they don't have their blood pressure under control. And we know that Black men suffer at higher rates when we talk about hypertension complications. So we're talking about cardiovascular disease. We're talking about heart failure. We're talking about kidney damage. We're talking about peripheral vascular disease, stroke. And unfortunately, we're also talking about death because we know, as we talked about before, the death rates among African-American males are higher. And quite frankly, that's unacceptable. So obstructive sleep apnea, what is it? So you either have recurrent episodes where you have complete or partial obstruction of your airway, and that basically leads to reduced or absent breathing during sleep. In my opinion, it's one of the most overlooked risk factors. We still have a lot better to do with number 1, screening for, and number 2, testing. And there are a few testing tools that are actually available. So whether you're in the outpatient setting, you can include in your pre-visit forms, or if you're in the inpatient setting, you can find an extra few minutes to just ask a few screening questions. The most pertinent probably to African American males will be the Stop Bank questionnaire. It asks questions pertaining to, do you snore? Do you feel tired? Does your partner observe you stop breathing during the nighttime? Or do they report that, oh, you know what? It kind of seems like when you're sleeping, you're kind of choking. Do you have a history of high blood pressure? What's your BMI? What's your age? What's your neck circumference? Are you male or female? And so those questions can be easily asked or assessed within less than 2 minutes. And then there's the Epworth Sleepiness Scale, which provides different scenarios, and it sort of asks, what's the chance that you will fall asleep during that particular scenario? So if you're sitting down and you're reading, is there a high chance that you're going to fall asleep, or is there a low chance? If you're sitting in a car as a passenger for an hour, what's the chances that you're going to fall asleep? Are you going to be awake, or are you going to be within the next 10 minutes out of it? And so again, these are screening tools that don't take a lot of time. They can be filled out primarily by the patient themselves, but what they do is it actually gives us an indication of whether or not someone is at risk, so that when we can then screen and then hopefully treat. And the reason that this is such an issue is that obstructive sleep apnea prevalence is increasing primarily because there's an increased prevalence of obesity. And the prevalence of stroke is strongly associated with obstructive sleep apnea. And particularly, the severity of obstructive sleep apnea plays a significant role in the development of stroke. And stroke incidence, as a result, increases with the severity of obstructive sleep apnea. What's most important when you look at this diagram, I want you to note, is that along with sleep apnea, it contributes to a whole host of other stroke risk factors. So hypertension, diabetes, hyperlipidemia, atrial fibrillation, coronary artery disease. So it's not a double whammy, it's not a triple whammy, it's just a huge whammy. Because if you have obstructive sleep apnea, you can then develop all of these other associated health conditions, which will also increase your risk of stroke furthermore. And even when you control for all the other independent stroke risk factors, obstructive sleep apnea is still a very, very, very strong stroke precipitant. Oh, I forgot I put those stars in there. So a growing body of literature, it supports that there are substantial racial disparities in the prevalence, in the risk factors, in the presentation, in the diagnosis, and the treatment of this disease when it comes to African Americans. African Americans usually experience a delay in diagnosis, and this usually leads to increased severity of disease at diagnosis. In addition, treatment outcomes are also suboptimal among African Americans. Among adults, the use of the CPAP machine is substantially lower. On a nightly basis, it's hypothesized that African Americans may use their CPAP machine about 60 to 90 minutes less than their white counterparts. One particular study found that African Americans were 5 times more likely to be non-adherent to their CPAP compared to their white counterparts. And when we look at this slide, I want you to recognize a few things. All age categories are affected and afflicted. There is a clear racial disparity, and we're even talking about pediatric patients. We're talking about children, we're talking about young adults. And even though the prevalence of the disease may sort of disappear a little bit when we talk about the middle age groups, as you get older, what you notice is that there's actually a tendency towards more severe disease, even if there's a similar prevalence with regards to disease amongst African Americans versus whites. And that severity has a 2-to-1 ratio. So there was the Jackson Heart study. And initially the study was done, and most of the study population is about 5,300 patients. They hail specifically, I think, from counties within Mississippi. And the study itself was designed specifically to study the etiology of cardiovascular diseases among African Americans. As a subpart of this study, we already know that African Americans have been underrepresented in obstructive sleep apnea research. And so part of the study chose to address the prevalence and correlates of obstructive sleep apnea overall, and also by sex among African Americans. And so, like I said, there were 5,300 patients between 21 and 95 years old. And when they looked at African American men versus African American women, African American men had a 12% higher prevalence of obstructive sleep apnea compared with their female counterparts. And the odds of actually having obstructive sleep apnea were associated with a few risk factors: older age, being male sex, we already talked about that, having a higher body mass index, having a larger neck circumference, and having the report of habitual snoring by a partner or someone else who may have observed them sleeping during the nighttime. The factors that didn't really play too much or have much of an impact were sleepiness and also weight circumference. So that's why when I talked about earlier, when we talked about the stop bang questionnaire on the Epworth sleepiness scale, the stop bang might be the best screening tool when it comes to the African American population, especially among males, because it looks for all those independent associated risk factors that we talked about. And then we come to stroke literacy within African Americans. And several studies have shown that while the majority of Americans don't have a basic understanding of stroke, stroke knowledge itself is actually poor among African Americans. And most importantly, a lot of these studies that I'm going to talk about or mention, or the excerpts from them, were not conducted amongst hospitalized patients, but they were actually conducted strictly within the community. And the first literary topic would be the location of a stroke. And this may seem like a very rudimentary question, but sometimes I think within the medical field, we take for granted what we consider to be basic medical knowledge. And if you ask anyone within the medical field where a stroke happens, they will tell you, oh, within the brain. But there was a survey that was conducted in, I think, Central Harlem, and they asked this question in a multiple choice format. And only about 56% of African Americans were able to get the question correct. And that was compared with almost 75% of their white counterparts. There was a similar percentage of correct answers when they did a open-ended survey in North Carolina in a few counties. There were about, again, 50-something% of African Americans versus almost 80% of their white counterparts. Within Detroit, when they did sort of this telephone-based survey, it was about 50% of African Americans, again, who were able to correctly identify that a stroke happened within the brain. And looking at inner city Baltimore, it was still in the 50s, so about 57% of participants correctly identified the organ affected. And this was when it was presented as a multiple choice question. When we talk about the signs and the symptoms, the most reported symptom that people tended to gravitate towards was headaches. There was a discrepancy with recognizing visual symptoms. There was a discrepancy with recognizing trouble speaking, with recognizing even confusion when comparing our African-American counterparts versus their white counterparts. And even when we talk about risk factors, there were significant knowledge deficits for the recognition of diabetes as a risk factor. There was a significant deficit for recognition of smoking or tobacco use as a risk factor. And when we talk about actions themselves, meaning, are you going to get to the hospital? What are you going to do if you witness someone having a stroke or stroke-like symptoms? African Americans are more likely to have delayed hospital arrival after the onset of stroke symptoms. And I can tell you from firsthand experience that this is absolutely the case. Racial disparities also exist in the awareness of what therapies are available. So initially, the beginning of the talk, we talked about TPA, or the clot busting medication that you can receive if you get to the hospital within 4.5 hours of your symptoms happening, or if you get to the hospital within 24 hours for a mechanical thrombectomy. I have had patients who their family members were aphasic. They could not understand anything that was going on. No one could understand what speech they were producing. They were weak on one side, clearly with disabling symptoms. And they may say, okay, well, they put them to bed, or they wanted them to sleep it off, or they thought the symptoms would eventually go away. And then 24 hours later, they come to the hospital, and there's nothing that we can do at that particular point in time because we've lost a lot of ground. And so knowledge doesn't necessarily always translate into action. And of course, there are other barriers that we always have to consider in terms of health insurance status, concerns about costs of stroke treatment, and really the trust within the healthcare system itself. But all these things need to be addressed. And specifically, when we talk about racial disparities and hospital arrival times, there was a study done, and this was actually, I think, in New York, I think in the Bronx. And it was a retrospective analysis of hospital arrival times comparing Caucasians, comparing African Americans, and also Hispanics. And it was about 2,000 stroke patients. And what they saw was that African American men specifically, they were more likely to arrive to the hospital late, meaning greater than 3 hours, and sometimes even more than 3 hours. And it's unfortunate because we know that, again, time is brain. And the cascade is very unfortunate because if your arrival is delayed, your ability to get acute stroke intervention is delayed. And if that's affected, your outlook with regards to disability, and then it's a whole domino effect from there. And so I always like to tell people, remember the acronym BFAST. Initially, the acronym was just FAST, and it involved face, meaning if someone had any facial asymmetry. It involved arms. You would ask someone to lift their arms up, and if one arm fell or if there was a noticeable weakness, I always, whenever I give this talk, like to tell people, don't neglect the legs. Sometimes you can have leg weakness and not arm weakness. If there are speech difficulties, meaning is their speech garbled in any particular way? Are their words slurred? Do they have trouble getting their words out? Do you understand anything that they're saying? And over the years, they've also added, they've also added assessments for coordination and also diplopia or visual loss. And so the B stands for balance. So if someone's losing their balance, they're leaning towards the right or the left, or they're unable to walk at all, or if someone's complaining of having double vision or having visual loss in one eye. Really, these were in an effort to try and include the most common stroke-like symptoms that can happen when strokes involve the arteries affecting the structures in the back of the brain. So if you can remember that and disseminate that, that's important, because the earlier you recognize the symptoms, the earlier you get to the hospital, the better your outcome will be, because at least you can be evaluated to figure out if you're going to be a candidate for those interventions. And that's the end. I think I made it in time.
Thank you so much, Dr. Edgecombe, for this wonderful presentation. We do have a few questions. I guess we can open it up to questions. You could, since it's a small group, you could unmute your mic and ask them. But Dr. McBride said, so OSA is a catalyst for other diseases that increase stroke risk?
Yeah, so like I said, it's so easy to screen for, and it contributes to so many other diseases that increase your overall stroke risk. So sometimes we may have patients that come in and they may be on the aspirin, and they may be on a statin, and they're like, I don't have any disease processes that are going on, and we're doing sort of a risk assessment and risk factor assessment. And the only thing that we come up with is that old OSA. And once it's present, again, if it's present, it's there, your stroke risk is significantly elevated, and it's correlated with your use of your CPAP, which tends to be a point of contention for a lot of people. Sometimes just having obstructive sleep apnea can be the underlying cause for someone having elevated high blood pressure. And once they start treating their OSA, then they may even eventually be able to get off their antihypertensives. So if you can do the assessment, if you can ask the questions, I feel like we all know somebody who snores very loudly in their sleep, and either we just kind of make fun of them and we're like, oh yeah, this happens, but it's a real disease process. And the more we bring it to the forefront, the more people can go out and get screened and get the appropriate diagnosis and treatment.
Yeah, and thank you for the acronym BFAST. That's how I found out that my mother was having a massive stroke. And unfortunately, I left for half of the day for work. And when I came back, she just was unable to say anything to me, but she was able to look around the room. And I thought, well, she was kidding me. And then she said she was having trouble earlier that day, you know, with seeing out of one of her eyes. I didn't know that that was one of the symptoms, but thank you very much. Fortunately enough, she was, even though she had a massive stroke, you know, it was just a total miracle that she was, she didn't have any damage and she was able to come home. So.
Yeah, and it's one of those things where if you don't know, then you don't know how, you don't have the barometer to respond. And people can have what's called a central retinal artery occlusion. And what that basically means is that instead of the blockage happening within the brain itself, that blockage can actually happen in the vessel that feeds the eye. And so what can happen is people report that their vision either goes completely cloudy or goes completely black. And when that happens, that in itself is actually a stroke emergency. And so if anyone has those symptoms, you should tell them, get to the hospital as soon as possible, because that usually is an indication that maybe you have a lot of cholesterol plaque or critical amount of cholesterol plaque in one of your carotid arteries, and a piece of that plaque basically broke off and went to the artery that supplies the eye. And those patients, if you find out that they have significant plaque within that carotid artery, if it's let's say about greater than 70% or more, then they're candidates for surgical interventions, whether or not they can go in and open that artery and scrape that plaque out, or depending on which risk factors they have or how safe they are to undergo surgical procedures, they may actually have a stent that goes in and is deployed to open that area up so that they're actually able to get enough blood flow. Some of the other symptoms that people are not aware of is that the structures in the back of the brain, they produce very specific stroke-like symptoms that can be passed off as something else. They may be passed off as, oh, they're probably dehydrated, or they probably have a GI illness. The structures within the back of your brain control your ability to move throughout your three-dimensional world without having to worry about anything feeling unsteady. And so the types of symptoms that people can have, they can have significant nausea and vomiting, primarily because your nausea and vomiting centers are located within the back of your brain. They can have a lot of gait instability. So they may walk like they're drunk, or they feel like they're on a boat, or like they need Dramamine almost. They can have a lot of diplopia or double vision. And it's, instead of their brain interpreting that things look like this is kind of what's happening. And that also can sort of set off a cascade. And headache is also very common symptom that can happen when you have strokes within the back of your brain, and even in the front of the brain as well. So I always like to tell people, if you notice someone who's walking a little bit unsteady, they're kind of veering towards the right or the left, they're complaining of nausea and vomiting, they're talking about double vision, get them to the hospital. it's always best to err on the side of caution and someone say, okay, well, yeah, this is probably an inner ear issue, or they probably have a GI illness, or they probably are dehydrated, versus missing a stroke that could have been intervened upon.
You know, you mentioned something that's like so important. You know, there was an incident with my mom where she actually had bilateral pulmonary embolisms, and people actually told her that she had anxiety. She came in with shortness of breath, sorry, and they told her that she had anxiety. And so I came down and I said, what you're going to do is you're going to get a CAT scan. That's what we're going to do today. And they diagnosed her with bilateral pulmonary embolism. So a lot of times, you know, and you spoke to this before, not only getting there, but also people believing you. And as we know, there's plenty of evidence regarding particularly Black women and Black men. People disregard their symptoms and their pain. So do you think that that could be a contributory factor, or have you seen those sort of things happen with your experience?
I have seen it. So not only do I do stroke, but I also do general neurology too. And last week, I saw a patient who about 8 days before started having weakness in his bilateral lower extremities. Now, he was in his 30s, he was moving around, he was independent, he had a history of drug use. And I think that was the stigma that was completely attached to him. He was Black and he had a history of drug use. And he went to 3 different hospitals before coming to our hospital. And the point that he came to our hospital, he was not able to walk. And every hospital that he went to, they passed it off as either he had taken something or was alcohol related, or that he was faking. But he had Guillain-Barré syndrome, which is basically a disease process that affects your nerves and inflames your nerves. And you get significant weakness. You get significant sensory changes that can happen. You can get a lot of bladder and bowel incontinence that can happen as well. And so this guy, over the course of 8 days, going from hospital to hospital to hospital. And when I walked in on him the second day, he was on the phone with his mother. And she was on the phone and she was so thankful. She was like, oh my God, someone finally believed you. And it is very real. The stigma that's attached to African Americans, and having someone believe off the bat that the symptoms that you're reporting are, number one, as severe as you're saying they are, and number two, that they actually exist, is pretty hard, which is why representation matters.
Wonderful. I have another question actually, because those slides were really good. So you presented something on your slide that said African Americans are more likely to have like OSA 20 at the age of 26 or above when compared to their white counterparts. And I know a lot of times people pass off, just like you said, snoring and stuff as sort of not that big of an issue. What do you think is the reason for that age? Like, because typically even in the stop bang, they ask you like, are you 50 or older? So, why is 26? Like, what's going on there? Do you have anything to sort of add about that?
The greatest association that we have with obstructive sleep apnea is obesity. So I don't know if that's probably playing a big role. And even for me, I have obstructive sleep apnea, and I myself probably, well, there was a clear delay in diagnosis for me, but that was my fault. Yeah, I probably was around the same age and it was just my friends were taking videos of me sleeping and they were making fun and they were like, this is not normal. Why are you snoring so loud? Why do you stop breathing? And I think for me, the delay in diagnosis was I didn't want to believe it, or I didn't want to have a chronic disease, or I just didn't think that, oh, well, I'm not obese, or I don't have a very large neck circumference. So anatomically, number one, African Americans are kind of predisposed to having obstructive sleep apnea, but I think also when you put onto that the component of obesity that probably increases that risk too.
Right. And the crazy part is, the younger you are, the less likely you are to go to the hospital. So, and I'm sure that many people on this call could corroborate that. So maybe this is something we really need to discuss in the community regarding making sure that if you are in a room with your or sleep in the same bed as a family member and you notice that they are snoring quite loudly, that's something that you should go through, even if they are thin, even if they are young. Given that particular age, I would promote it even heavier. And I may even start telling people to go get screened at earlier ages as well. I think that was a incredible statistic that you gave us.
Yeah, I definitely would. And because, sometimes the default, and I hear this, and it's especially among patients that are married, the default whenever someone is snoring or they're having episodes like that is that they'll say, oh, well, I'll just go sleep in the next room. My answer to that is no, don't go sleep in the next room. You guys can sleep in the same bedroom. Go to a sleep clinic or a sleep doctor and get evaluated so that you don't have to sleep in a different room. You can sleep with your partner. And yeah, so the more we can disseminate and get that information out there and say, hey, if your partner snores, if you feel like they're gagging whenever they're sleeping, if you're waking up and you're not refreshed, these are things that you need to sort of address. And yeah, and there's so many sleep devices that are out there. Most people think that you have to have the full mask. You don't. It depends on if you're a mouth breather or if you breathe through your nose when you're sleeping. I just have the nasal pillows, which are actually very comfortable. And once you start using that CPAP machine, you realize you were missing out on so much refreshing sleep throughout your entire life. And so it makes you happier and you more fit and reduces your stroke risk. It makes your partner happier in the long run. So it's a win-win for everybody.
Should do a PSA on that.
Yeah.
Oh, really? That's a great one.
Yeah.
We also, Dr. McBride, we have that sleep clinic, so that would be great to figure out a project. I just have one additional question, and I'll ask our panel members if they have any. But we're starting a barbershop initiative. I guess Mount Sinai was the first to do it around blood pressure and diabetes screening, but this one happens to be around blood pressure. Is there anything that's been done around stroke and stroke prevention and wellness? And if that's the case, is it being done in underrepresented minority communities, specifically the Black African American?
Well, there was a review that came out, I think back in like 2020 about hypertension in the African American male. And everyone tries to use the same strategies in terms of trying to reach out to community leaders to figure out how to disseminate this information, because they realize within the community that's sort of the way to get out there. So whether it's through barbershops or whether it's through talking with church leaders or whether it's through talking with, let's say, recreational centers, that seems to be the best way in terms of getting the information out there, trying to get people sort of familiar with what normal blood pressure numbers are, what the effects of long-term issues of hypertension are, trying to get them to understand that just because you don't feel that your blood pressure is high doesn't mean that it's not high. And yeah, so there hasn't, all the things that you're talking about are just all the things that have always been done. There's nothing specific besides sort of reaching out to, let's say, community leaders or the areas where we feel like African Americans tend to congregate or get the majority of their information from, whether it's in regards to health or anything else.
Thank you. Do we have any more questions from anyone? Well, Dr. Edgecombe, you have done a fantastic job. I am sure we will go out and repeat what you said. So that may save or educate a few more people. And I'm planning to even put a PSA on my social media site. So thank you once again. You did a great job. And I think I turn it over to Oshi next.
Shay. Hi, thank you everyone for coming today. And thank you so much, Dr. Edgecombe, for the presentation. Can everyone hear me okay? I have my headphones in, so I never know.
Yes.
Okay, awesome. Thank you so much for that presentation. It was very informative. And like you rightly said, I didn't know the role of sleep apnea in increasing the risk of stroke. So I too will be sharing that information with the Black men in my life and just everyone around me. I just wanted to also remind us all that we do have the ongoing community dialogue, Fight for America, that's taking place on Tuesday, June 8th at 5 p.m. Please make sure you register. And also we have our next session next Wednesday, June 9th at noon. And it's gonna be led by our very own Dr. Dara McBride, who is gonna be talking about HIV and other STDs, the statistics, treatment, and prevention, a focus on Black men's health. So please make sure you're sending the links in your group chat, to your network, to make sure that everyone is aware of this opportunity to learn, and for us to just come together within this this network to kind of, you know, further our knowledge of what it means to be a Black man, and also like taking care of their health and knowing what it and knowing more about their health. Like, you know, we just learned here today, like awareness is so important. A lot of us are missing out on things that we just don't know. And so many issues could be prevented if we can just, you know, learn. So please make sure you're sending that information out to your network, your social media. And that is all that I have for today. Thank you again to our guests, and thank you to everyone who attended. It was such a pleasure to be here with you all this afternoon. Enjoy the rest of your day.
Thank you.
Thank you.
Thank you. Sign up for all the events.